Welcome back to Reimbursement Readiness, Business Tips for Wound Practice. I'm Donna Cartwright, and Kathleen gave me a very nice introduction, and we're going to talk about one of my favorite topics today, wound versus ulcer. Boy, I can tell you, as Kathleen said, selecting the correct diagnosis codes is a total mystery for a lot of the physicians that are treating these because they don't basically understand that there are different code sets for wounds versus ulcers. So I'm going to talk to you a little bit about both of those types of code sets and when you should be selecting one or the other. So the frequently asked diagnosis coding question, should I report a wound or an ulcer ICD-10-CM code? And the answer from a coding perspective is basically, if it's an acute wound, it is a wound. If it is a chronic wound, it is an ulcer. So that's a simple answer, but we're going to get into a lot more detail as far as this is concerned. So let's talk about acute wounds because those are more unfamiliar in the wound care practice to many. And I wanted to go over some of them so that you know that there are codes for these things. And if this is the diagnoses for the patient that you are treating for today's encounter, these are the types of codes and terminology you may see. So for example, superficial injuries, abrasions, blisters, contusions, external constriction, superficial injuries with foreign bodies, insect bites, venomous and non-venomous, as well as other superficial bites. Open wounds, they can be lacerations with or without foreign bodies, open puncture wounds with and without foreign bodies, and trauma wounds. Skin trauma, partial and total traumatic amputations, burns, corrosions, crush injuries, open fractures, and frostbite. Wounds caused by other acute diseases, such as acute and subacute osteomyelitis. And then, of course, you have surgical complications that are frequent in the wound care business for surgical complications of grafts and surgical wounds, as many of you are taking care of patients that have been transferred to the wound center from having an acute episode of care as an inpatient, and the wound center is following the wounds. So I wanted you to be sure to get a clear understanding of all of these terminologies that you will find regarding the acute wounds. So all acute wound codes appear in Chapter 17 of the ICD-10-CM book for chapter injury, poisoning, and certain other consequences of external causes. The key word there is external causes because acute wounds are caused by some external force on the body. Okay? So all codes in Chapter 17 will require a seventh character of either A, which represents an initial encounter, which means active treatment is being rendered to the wound. Subsequent encounter is D, and that is for the same wound that you treated previously, or it can also be S, sequelae of the original wound. So I wanted to give you some examples of foot injury acute wounds. So here we have crushing injury examples. So you have crushing injury of the right foot. So the main code is S97.81, but you'll see underneath that you can have crushing injury of the right foot, initial encounter, crushing injury of the right foot, subsequent encounter, and the last would be sequelae of that crushing injury. And then, of course, then you have the same set of codes for the left foot, initial, subsequent, and sequelae. What we have created, what I created for you is let me start that over again. What I've created for you is a wound document that has many examples of acute wounds, which you are free to print out and use as a cheat sheet. And that may help you when you're asking yourself that question of, is this wound an acute wound versus a chronic wound? So chronic ulcer terms in ICD-10, we've discussed before in the vascular diseases episode and the diabetic ulcers episode. So some of those chronic ulcer terms you're familiar with: atherosclerotic disease with ulcers, chronic osteomyelitis, diabetic ulcers, non-pressure ulcers, pressure ulcers, varicose veins with ulcers. So we've covered a lot of those in previous 2 episodes, but we're going to dive into it a little bit deeper. Chronic ulcers usually have an underlying cause associated with that ulcer. So for example, you could have diabetes, venous disease, and so forth. Chronic ulcer codes are not in Chapter 17 of the ICD-10 codebook. So chronic ulcer codes do not require the addition of that 7th character that we spoke of before for acute wounds. So they don't require the A, S, or D. Now, what I did was create another chronic ulcer document for you to have as a cheat sheet, and it will give you some of the more common chronic ulcer codes so that you have them to take a look at when you're trying to make that decision as to what do I have here. So underlying causes for chronic ulcers, this is the same information that I provided you for vascular ulcers, which were in the vascular episode. So of course, the underlying causes for chronic ulcers can be atherosclerosis, chronic venous hypertension, diabetic ulcers, post-phlebitic syndrome, post-thrombotic syndrome, and varicose ulcers. So an example of chronic ulcers, it can be a chronic multifocal osteomyelitis of right ankle and foot, or chronic multifocal osteomyelitis left ankle and foot. The chronic osteomyelitis with draining sinus, let me start that one over again. I didn't move, so my lights went off. Some examples of chronic ulcers in the alphabetic index: chronic osteomyelitis. So you can have chronic multifocal osteomyelitis, right ankle and foot. Now that would be one of the underlying causes, and then it could also have an ulcer code that goes along with it from the L97 category for non-pressure ulcers. So a reminder about the first listed diagnosis code. So for every encounter, you have some opportunity to pick the first listed diagnosis code. And the diagnosis for each encounter is the diagnosis that caused the patient to be seen in your office or the clinic for that date of service. So for example, a CTP was applied to a diabetic foot ulcers, and I gave you the code for several weeks. The last application of that CTP became dislodged. So the diagnosis code switches from a diabetic foot ulcer to the dislodgement codes of CTPs, which is postoperative complications. And I gave you some of the examples of postoperative complications for dislodgement and so forth, so that you can have some to pick from. I have seen so many times in clinic records and physician office records that basically once it's an ulcer, a diabetic ulcer, that diabetic ulcer is the diagnosis first listed, and it could go on for 20 weeks, 30 weeks, however many weeks. But that is not necessarily the reason for the visit every single time. So the basic rule of thumb: code each ulcer or wound separately. When you have multiple wounds or ulcers, and if one code is one character different, report both codes. So if any of the characters changes by one character, then that identifies a different specific site of the wound or ulcer, and especially if multiple sites are treated at the same time, because you want to relate the treatment to each of those diagnoses. So from a coding guideline perspective, there is no timeline during which an acute wound becomes a chronic ulcer. Now, a lot of clinicians may say that it's 30 days. Some clinicians may say other time frames, but technically there is no coding guideline that says at X amount of time an acute wound becomes a chronic ulcer. And don't forget, in the acute wounds, you have the initial encounter, subsequent encounter, and sequelae that are due to the acute wound. So, and as a reminder, a non-healing surgical wound is listed as a complication in the injury chapter of the ICD-10-CM code book. So that's an important reminder. As I said earlier, many of the wound care centers or some of the wound care physicians may get patients transferred after an inpatient stay for wound care post their surgery. So, and a lot of times you may be faced with a non-healing surgical wound. So those are in the acute injury chapter of the ICD-10-CM code book as a surgical complication. So the progress of all acute injury and wound codes in Chapter 17 are delineated again by using those 7 characters of A, D, or S. You always match the treatment rendered to the appropriate wound or ulcer site code. Multiple wounds or ulcers may often receive different treatments on the same date of service. Linking the right diagnosis code to the treatment makes it easier for a payer to understand. And just so you remember, your coder and your biller there's a space for them to link one of the listed diagnoses to treatments that are being billed for. So that is the opportunity to match. So if you have a right and a left, it's important to use those specific codes, for example. Multiple wounds or ulcers may often receive different treatments on the same date of service, and linking the right diagnosis code to the treatment makes it easier for the payer to understand what happened to the patient. The longitudinal treatment of a single wound or ulcer and which treatment was provided to each wound or ulcer. Again, when you are coding, you're telling the story of the patient in characters that are represented on the bills, and that is the payer's rationale and way to figure out what's happening to the patient on that encounter. If an infection is present, use additional codes to describe the infectious agent, such as staph or strep or whatever the infectious organism may be. If the infection is due to a surgery, either an application of CTP, or you had a transfer in from other for example, an orthopedic procedure, and the wound has an infection, you're going to use the post-op complication codes from the orthopedic part of the acute wounds. If the infection is not due to surgery, you're going to report the additional infection code for the organism, as I said before. And from the coding perspective, the code for the underlying cause of a chronic ulcer is usually listed first, and the type of ulcer. So for example, pressure ulcer or non-pressure ulcer is listed second. However, I give you a caution because some commercial payer coverage guidelines often require the chronic ulcer code to be listed first. So it is very important that you check the patient's insurance and their coverage guidelines to make sure that what order they expect to see, because some of them will not pay if you put, for example, diabetes as the first code and then the ulcer as the second code, because their belief is you're treating the ulcer. But the correct coding guidelines tell you that you're supposed to code the underlying cause first and then the manifestation, as we've talked about in the diabetic ulcer and vascular chapter. If a complication is related to a previous open or traumatic wound that has since closed, use the site of the wound with sequelae to indicate the relationship to a previous wound or injury. So this would be if an acute wound opened. For burns, it could be a scar. That would be a sequelae of an original burn wound. The first listed code for an outpatient clinic or office visit may not always be the wound or ulcer itself. It could be a complication, an infection, and/or a new wound or ulcer of a different site. So you always have to ask yourself, what diagnosis required most of the treatment during this clinic office visit? That's very important because that helps to tell the story of the patient for that encounter. I hope that this episode has clarified some of the confusion about wounds versus ulcers and provided some specific examples to think about. While this episode is not all-inclusive, it should be indicative of how, from a coding perspective, acute and chronic ulcers are delineated. Physicians and other qualified healthcare professionals should know whether to diagnose the problem as a wound or an ulcer. Please send any questions to Kathleen Schaum at kathleendSchaum@gmail.com, and we will respond to your questions in another episode. Have a great day, and thanks for watching.